All right, we're back, and Jerry is back for a workshop on challenging glomerular biopsy cases.
Great. Okay. Am I all set to go here? Great. Hello, everybody. So these are going to be challenging cases from the Glomerular Center at our Glomerular Center at Columbia University. Now, I will say that I know Helmut went through some challenging pathology cases. We will have pathology in each of these cases, but the challenge in many of them will be how you will treat the patient. So we'll get to cover a bunch of the things that I couldn't cover in those past lectures. So let's proceed right ahead. Okay. Oops. Okay, that was just my disclaimers, which are the same as before. So this first case is a patient who has CKD with a history of uveitis in the past, positive crime test, but never had sarcoid. But his known diseases were Crohn's disease and hypertension. And he also had psoriasis, which you'll find out along the way. He's been treated with quinapril, an ACE inhibitor, allopurinol, atenolol, and risankizumab. He had been on infliximab for his Crohn's disease and his psoriasis, but was switched to risankizumab, which is an IL-23 blocker, which works in both of these diseases. His background is that he's a pharmaceutical, not a representative, but a pharmaceutical worker for a company which we will not mention today. His blood pressure was slightly elevated at 154/87. That comes in with a creatinine of 2. His baseline, we know, is 1.1. He has 3+ proteinuria, 4+ blood on the dipstick, and 4 grams proteinuria per gram of creatinine. His albumin is somewhat low. The serology that we got, ANA, anti-DNA, ANCA, C3, C4, were all unremarkable. So what's our differential diagnosis here? So it's pretty broad. I mean, we don't have any good serology markers in terms of this. That do we know he has a glomerular disease? He has proteinuria. He has hematuria in terms of this. What other labs would we send? Well, there are a number that you might pick in terms of this, but I can tell you that this wasn't a lab diagnosis. At this point, would we change his medicines? This is a person who was recently put on risankizumab. Okay, so again, we're talking about this IL-23 blocker, which he's only been on about a month or month and a half. And again, is it this medicine that does it? Is it stopping the other medicine that did it? We don't know. So would we change his medicines? Well, the answer is probably yes. And would we do a biopsy before any other treatment? And that I can tell you is certainly yes. And anytime we have a biopsy conference thing, you know that there's going to be a biopsy. But here I would certainly be thinking about this. So risankizumab was held after discussion with the gastroenterologist and the dermatologist because he was being treated both for his colitis, his Crohn's disease and his psoriasis, and the kidney biopsy was performed. So here's what we got on the biopsy. So you're looking at a glomerulus here, and most of the glomerulus here just shows areas of sclerosis in terms of this. But here with the arrow, you can see a significant fibrocellular crescent. Okay, so again, this explains the rise in the creatinine if he has crescents. Here again, another glomerulus, and this has another fibrocellular crescent. The basement membranes look pretty thin, but again, this is clearly an indication of active glomerular disease. When we looked at his IF, he had IgA deposition and no IgG at all. He had lambda and kappa present. So it's not monoclonal, it's IgA nephropathy. And indeed, if you look at the arrows here, you can see along the basement membrane that he had electron-dense deposits here, and he had them in the mesangial area as well. So this person has IgA nephropathy, but he didn't have it before. He was being followed for 2 diseases, and even his routine screens didn't show proteinuria and they didn't show hematuria. So the final diagnosis was IgA nephropathy with proliferative and sclerosing GN with crescents. Now, it's very important that only 2 of the glomeruli had crescents because his MESTC score, his IgA score, was M1, E1, S1, T1, C1. So that's a complete one finding here. Mesangial 1, endothelial perforation 1, segmental sclerosis 1, tubular interstitial fibrosis 1, crescents 1. One of the important things to realize when you get a biopsy back like this, the C1, which can be very important, the C1 is a range of crescents. It can be anywhere from 1 to 24% of the glomeruli with crescents, and that's a C1. To get a C2, you need more than 25%, 25 or more percent of the crescents. So again, he has 2 crescents, but it's not a fulminant crescenteric. And this is something that often confuses people about IgA nephropathy. So the MEST score is very valuable here. It certainly shows scarring and it certainly shows proliferation, but it has 2 crescents there as well. So here are questions for this case. Is this risankizumab related? If we stop it, will he get better? Or did he need something else? What will we do about his Crohn's disease and his psoriasis if we stop it? This is a medicine that works well against these diseases. So this is something to think about when you're thinking about his treatment. Does he need therapy directed against the IgA nephropathy? Is this somebody that we can just say, look, let's stop these medications and see how he does? Well, the answer is, for the first one, you can't leave him alone with a Crohn's and psoriasis, because if he gets a flare now, it's going to be a mess trying to treat his kidney disease with other diseases going on as well. Secondly, does he need therapy? Yes. He's got an active disease. The E1s usually respond well to immunosuppressive therapies that S1 and T1 don't respond to anything. And the C1, in his case, because it's 2 out of 30 glomeruli, is not a fulminant, rapidly progressive GN. So he's on an ACE inhibitor already that we could consider for IgA: SGLT2 inhibition, sparsentan, steroids, targeted release budesonide, that should be TR budesonide, mycophenolate, or other immunosuppression, because again, he does have some crescents. So this is somebody who the biopsy makes the diagnosis, but now we have to ask ourselves, how would we treat him to cover his other diseases and at the same time treat this active glomerulonephritis? His creatinine, as we pointed out, was up to 2 when he started therapy. So a couple of words about this. First of all, if we look at steroids here, probably the most important study here is the testing trial. Okay, so here you're looking at 500 patients here that admittedly, most of them were from China, but, again, there were Australians in there are people from India, etc. That if you looked at the patients, a treatment course of lower dose steroids than they started with originally, because they started with high dose steroids and they got good results renally, but they had more infections and more mortality. The second half of the patients got lower dose steroids to start the taper, and those patients had the same good results. The placebo group here had 43% of the patients having a decline in GFR of 40%. The treatment group only had 30%. And if you take renal failure, death, etc., everything was better. You use the reduced dose. So lower doses of steroids, by lower doses, we're talking about 30 to 40 milligrams a day of prednisone. If you start with that and taper over time, over 6 months, it does work in proliferative IgA nephropathy. The other thing that we now have is targeted release budesonide. So this is a non-absorbable steroids. The results of a 2-year trial are out already, and it's pretty clear if you follow these patients over time versus placebo with their IgA nephropathy, they end up with a better GFR. Now, the interesting thing is the treatment is for 9 months here. The dose is 16 milligrams a day of targeted release budesonide. You then stop the drug and follow it for another 15 months. That's what the FDA wanted to say, we'd give you approval. At the end of 15 months, they're getting no therapy in here. You can see they have a better GFR than the placebo group, and the proteinuria, which came all the way down, was still better after this period of no therapy. So treatment in here in the beginning 9 months and then no therapy, and you still come out better. So clearly, they reached the endpoints the FDA wanted, and it's FDA approved specifically for IgA nephropathy. Sparsentan, a combined molecule which has an endothelin antagonist and an A2 receptor blocker in there, irbesartan, that did well, like irbesartan. If you look at this here, it did reduce proteinuria more significantly. The GFR has a strong trend towards improvement. It's already gotten approval in Europe. It is not yet approved, FDA approved in the United States. The studies are still ongoing. They're in front of the FDA. We'll see. But again, it does come out better than placebo. Not placebo here. Placebo, or the placebo is irbesartan. There is no placebo. It's irbesartan versus sparsentan, and the sparsentan did lower the proteinuria more. So what about immunosuppressive therapy? In the past, we've steered away from this recently, but now we say steroids work, and there is enough evidence, which is increasing, that mycophenolate may. Here's a study that compared mycophenolate and low-dose prednisone to a full dose of prednisone. And if you look here at the response rate here over time, it is absolutely the same, okay? If you look at, here's the mycophenolate, this plus steroids, and here's the steroids alone. If you look at how many got cushingoid, many fewer here. How many developed diabetes, many fewer. Infections were reduced as well, and were really about the same between the groups. But again, no significant increase. So given this suggested mycophenolate may work. Here's another one of mycophenolate and steroids. Again, very similar results. Creatinine actually down a little bit more, proteinuria down about the same. And here's a study which looked at mycophenolate here versus optimized supportive care. And again, most of these studies are coming from China, which is where they did the testing trial largely. But again, if you look at this over time, death, end-stage renal disease, or doubling of the creatinine, here, if you look at the mycophenolate group versus the placebo plus standard of care, you do better here. Again, so this is CKD progression is down. So there is data that you could treat this person with mycophenolate. So what did we do in this case? We started him on prednisone and mycophenolate. Now, again, he is very savvy. As I said, he's not a rep. He does something for, this pharmaceutical company that, but scientifically very savvy. And his father is a neurologist. So we were getting some very intelligent people, well-informed in terms of this, and help make the decision. We eventually titrated up the mycophenolate to 1,000 milligrams twice a day. At 2 months of therapy, his creatinine was down from 2 to 1.5. Proteinuria dropped down to 1.5. 6 months later, 1.5, 0.2. 8 months later here, which is in February of this year, his creatinine is between 1.3 and 1.4. His baseline, remember, was 1.2. He's a big guy, and the proteinuria is 0.4. So now, at this point, we talked about, should he stop the mycophenolate or should he taper it down? That his feeling was he'd rather not have a relapse. He was tolerating it perfectly. He said, I'd rather stay on it a little bit longer. Let's ask me that question in another 3 to 4 months. So he's doing pretty well here. So some thoughts about this case. First of all, no two patients with IgA nephropathy are the same. That you have to individualize therapy now. We have so many different therapies here and we have things that work. We know they work over time. They just haven't been compared to each other. So some people will need steroids, some people will need mycophenolate, but many others, optimal therapy. It's certainly clear that some patients just renin-angiotensin system blockade and SGLT2 inhibitors work now, or sparsentan. This may be enough without true immunosuppression. But not in everybody. If you see crescents, etc., a lot of proliferation, you may say, look, I want to use real drugs and immunosuppressants here. You do have to think about targeted release budesonide, which is FDA approved now for IgA nephropathy, and sparsentan, which has a very good chance of getting approval for it too. In terms of final approval, you can get the sparsentan. I mean, it's approved preliminarily now based on the reduction of proteinuria, but we'll see if they get the final approval here. And the MMS studies have shown good results in Chinese patients and certainly can be considered likewise steroids here. I have a tendency to use much more targeted release budesonide now than steroids for these patients. But again, that's my preference. Some thoughts about that first case. Okay, let's go on now to a second case. So this is a 32-year-old female who presents with 8 grams of proteinuria, hematuria, hypoalbuminemia. She's had edema, foamy urine for a period of at least a year. No rash, no other joint symptoms, no other manifestations. Past history is unremarkable. She's Chinese background. She actually moved to the United States. She's an immigrant. She moved to the United States in 2014. Family history is unremarkable. She has a lowish blood pressure, 105/65. She has bilateral pedal edema. Her BMI is quite low, lower than somebody that probably was born in the United States. But her creatinine is 0.4, 3 plus proteinuria, trace blood, 8 grams of proteinuria per day, albumin 1.9, cholesterol way up there, fully nephrotic, without a doubt. That ANA complement, Hep C, that SPEP, UPEP, all negative or unremarkable. She's hepatitis B surface antigen negative. She's core antibody positive. So think about this. This is a fully nephrotic patient, and she has a history of edema and foamy urine for at least a year. So first of all, what's your differential here? Well, there are a number of different possibilities. The ones I'd say are less likely. Minimal change is less likely. That's usually sudden onset with very heavy proteinuria. In our series from Columbia of 95 patients with adults with minimal change, the average proteinuria was 10 grams a day, and they presented very quickly because they all got very edematous and had lots of fluid retention. Secondary focal sclerosis, not that likely either, because the proteinuria is pretty heavy here and the albumin is low, and secondary forms of focal sclerosis usually have more normal levels of albumin and 2, 3, 4 grams of proteinuria. Membranous nephropathy, yeah, certainly possible. And IgA nephropathy can certainly have a nephrotic picture. So you could present with a nephrotic, but again, that it's not the most common presentation of IgA. So statistically, if I had to guess in this case, I'd guess membranous, but I'd say I'm going to find out for sure. What additional tests would we do in this patient? Okay. Should we get a C3 level? Well, I can tell you complement is one of the most useful tests to get, and I get it in every patient with glomerular disease. That's one of the 2 things I get in everybody, an ANA and a complement. I get a total complement or a C3 and C4 because there are only certain diseases that give you low complements. We'll talk about this later. I get an ANA because it tells you about lupus, collagen vascular diseases. It tells you about anticardiolipin syndrome patients, etc. Antibody to PLA2R, well, this is becoming pretty standard now in terms of this. If you look at patients in terms of, who come in with nephrotic syndrome to Columbia, the house staff don't think twice. I mean, they just get an anti-PLA2R just like they would get an ANA or a complement level. So that certainly makes sense. Anti-GBM. I personally reserve ANCA and anti-GBM for people who have a nephritic picture that where their creatinine's going up and they have active sediment, et cetera, things that make me think of either an RPGN or even just an active glomerulonephritis, not a nephrotic picture. So of these things, certainly the antibody to the PLA2R should be done. Should a kidney biopsy be done in this patient? Yes, no, maybe. Well, a glomerular lecture on biopsy cases, always do the biopsy. Well, that doesn't take a lot of sense in terms of this. But in reality, if you had a strong positive PLA2R and there were contraindications to biopsy, you might not want to do a biopsy. So if somebody presented with nephrotic syndrome, like I had a 94-year-old guy who came in. He was a pastor. He had very heavy proteinuria. He had heart disease and a bunch of other things, and his PLA2R was very strongly positive. And we decided, no, we'll pass on the biopsy. We'll try treating him and see what happens. I've also had an NFL football player who presented with nephrotic syndrome. And he wanted to get back playing as soon as possible. And, the whole question about doing a biopsy and having him miss a bunch of weeks of play was a bad thing. So if you can get a positive PLA2R, you may not need the biopsy. Most of the time, I would still do it. So this is what we found in this second patient. In this lady, we found that her glomeruli didn't have much proliferation. You could argue a little bit of proliferation here, but again, it's more than 4 nuclei in a area away from the glomerular tuft, but those are controversial. Whether are there 4 or there 3 here, whatever. One of the things is that you look at this and basement membranes, which look pretty good, but if you look very close here, you can start saying, something a pathologist would say, wait a minute, that's not entirely normal. And when they do a silver stain, and the silver stain brings out the basement membranes best, so you can see here the glomerular, basement membrane here, looking at the Bowman's capsule, and you can see every tubular basement membrane. And if here, of course, looking at these, the most prominent thing is if you blow this up to high power, you can see that there are little positives and negatives. It's not, someplace it looks like spikes, someplace it looks like bubbles here in terms of the basement membrane. If you do a trichrome stain, which is done here, you can see at the arrow, you can see, again, little red deposits here on the epimembranous side. So you're going to say, and you can see these in many capillary loops, so a pathologist already is going to say, this is a membranous case. Clearly, there's no increase in proliferation. You can see on this glomerulus that, but it is, sometimes they say the capillaries are a little bit rigid, but here you're saying, look, this is pretty clear in terms of this case that this has epimembranous deposits. The other thing that was very prominent in this case was foam cells. So foam cells here, you can see in terms of the arrow, these are cells in the interstitium that are filled with lipid that they're often found in people who have long-standing nephrotic syndrome. People used to think it was very typical of Alport syndrome with heavy proteinuria, and it is if you have heavy proteinuria, but you can see it in almost any form of nephrotic syndrome where it hangs around for a long time. Their clinical significance is very small, though. They don't influence the course or treatment. So what do we have here? We have somebody who looks like membranous by light. We should see IgG by the immunofluorescence, and we do. Here, as you can see along the basement membrane, you can see very clear little deposits all along the basement membrane here of almost every capillary loop. They're not continuous, okay? But again, they're deposited there. If you look at the PLA2R is positive. So here we have somebody with PLA2R positive membranous, which again, about 70% of the patients with idiopathic, quote, membranous will be PLA2R positive. Now, I know Dr. Falk gave a lecture at the beginning of this course on minimal change focal sclerosis and membranous, but he was covering all of them. So you can't really give good due to membranous if you just talk in the whole bunch and you have to concentrate on treatment and everything. There's much you can say just about PLA2R positive membranous. And we will come back to this. But here's what you see by electron microscopy. Here you can see at the arrows, you can see epimembranous and intramembranous deposits all along the basement membrane. So they're not in a subendothelial space. They're on the membranous side in terms of the subepithelial side. So this is a case of membranous. And since the PLA2R is positive, it's a case of PLA2R positive membranous. Okay, so the diagnosis was PLA2R positive membranous. Okay, there is some tubular atrophy and interstitial fibrosis. Prominent foam cells are very interesting, but don't influence our course. So how would we treat this patient? How would we go ahead and treat a patient whose PLA2R 2R positive. That, again, this is a very common thing, and most of you have treated patients like this, and we're going to talk about a little twists in the case. So the KDIGO guidelines here. Now, remember in my lecture on lupus, I talked about the KDIGO guidelines from 2024, from January 2020. These are guidelines from 2.5 years ago. And you may say 2.5 years doesn't make a lot of difference, but in glomerular disease, it's a lifetime. We have so many new medicines, in IgA, we have budesonide, we have sparsentan, we have Farxiga, and et cetera, dapagliflozin, empagliflozin, et cetera. We have a lot of new drugs and new therapies. In any case, the KDIGO guidelines say if you're low risk, less than 3.5 grams of proteinuria, just wait and see. If you're moderate risk, normal GFR, proteinuria over 3.5, but no decrease in recently, you can make decisions on this, okay, and that's moderate here. If it's higher risk, that's over 8 grams a day for at least 6 months, okay? You have rituximab, cyclophosphamide plus steroids, calcineurin inhibitors plus rituximab. And if you're very high risk, they would just recommend cyclophosphamide and glucocorticoids. That's life-threatening. Again, people would do some things very differently 2.5 years later. This patient has significant proteinuria in terms of it was 8 grams a day, a very low albumin. She's somewhere between, the high-risk patients, not very high. She hasn't had anything life-threatening. In fact, she came to us, just because she was sent to us by her private local doctor. I mean, she was following with edema and probably urine for a long time. So this patient is hepatitis B core antibody positive. Does this say we should delay therapy? Should we treat it at this point? What if the patient was PLA2R negative on biopsy? Would you ask the pathologist to do special stains? Does it make a difference if they're positive for NEL1 or thrombospondin 7A, 2 antigens which are found in membranous? We have to think about this in 2024. So first, hepatitis B and B-cell depleting therapy. If you're thinking about rituximab, I would say the same thing for cyclophosphamide, which is a B-cell depletion drug here. Again, that reactivation of hepatitis B can occur with immunosuppression, especially with immunosuppression and high-dose glucocorticoids. Okay, so if you use high-dose steroids, that rituximab or cyclophosphamide, you should really think about hepatitis B. Patients who are hepatitis B antigen positive and core antibody positive are at the highest risk, but there's still a black box warning for using many of these therapies like anti-CD20 therapy, rituximab, using a monoclonal rituximab, if you're using any of the other anti-CD20, obinutuzumab, ofatumumab, any of those, there's black box warning in patients who have antigen negative but are core positive because they're considered at moderate risk for reactivation. And the prophylaxis should be continued for about 6 to 12 months after, while monitoring serology. So we have to think about the hepatitis B. And what if this patient were PLA2R negative? So NEL1 is turning out to be a not rare form of membranous, but it has special connotations. Now, many of you have heard about thrombospondin 7A, and that is an antigen which has been known for a number of years to be associated with membranous and has a higher risk of tumors. Here's a staining of a membranous patient in Colombia with NEL1 staining, and you can see the brown. This is immunoperoxidase. They use immunoperoxidase for NEL1 and thrombospondin 7A. You can see it's strongly positive. The brown is positivity here. So there's a great paper by Tiffany Kaza from the Arcana group. She looked at 91 NEL1 membranous patients compared to 829 PLA2 positive and PLA2R positive patients and 37 thrombospondin 7A. It gives you an idea how common these are. NEL1 is more common than thrombospondin 7A. But most people know that they have to do something special if you have thrombospondin 7A staining. Now you have to think of NEL1. So it was often segmental staining. It's often IgG1, not IgG4. You saw our patient was IgG positive, but she's PLA2R positive. She's going to be an IgG4 staining here. 33% of them had a concurrent malignancy here. It's a much greater proportion of malignancy than you would find with PLA2R. So this just shows you their series there, okay, from Kidney International. And if you took PLA2R positive patients, 4% of them had a malignancy. Now remember, a lot of these are older patients, and that's not surprising. 10% of the thrombospondin 7A had a malignancy. A third of their patients with NEL1 had a corresponding malignancy. So again, some people have said, well, we don't find it quite up that high. It's still higher than it is for PLA2R. You have to do a more thorough malignancy search. So this shows you a paradigm, shows you a flow diagram of what you would do when you have a membranous nephropathy patient. This is taken from a paper that Andy Bomback wrote that for the oncologists and the onconephrologists. But if you're PLA2R positive, you would just do the age-appropriate cancer screening. There's no increased risk of cancer in these patients. Yeah, if they're above a certain age, you might do the SPEP in terms of this. You'd look at their PSA, like you might, make sure their bowel's okay, but it just age-related. If it's negative PLA2R, or if it's negative and positive thrombospondin 7A, or now NEL1, you would do not only the age-appropriate, but somebody who's older, somebody who has a smoking history, the more thorough, you would do the same thing. You would do a CAT scan in all of these of the lung in terms of this. You would run their gut in terms of this. You would make extra sure they don't have a malignancy here. Now, if they're negative for PLA2R and they're negative for thrombospondin A, then they're back to doing the same thing. But the same thing, NEL1 has the same connotations as thrombospondin 7A. So what happened to this patient here? So she was treated with TAC for about a year, okay? And again, that's one of the choices. This was more by her preference than anything else, that she got a complete remission with the urine protein creatinine ratio going down to 300 milligrams per gram. And the PLA2R came all the way down to less than 1 to 10. The TAC was tapered over time here. And then, while later, her PLA2R turned positive, her proteinuria started to go up. The TAC was increased, but she still only had a partial remission. A little bit later than that, she had a very high PLA2R level with 9 grams of proteinuria and an albumin that's down to 2.3. So she clearly has activation of her membranous. Now, if you didn't have the PLA2R, you might say, do you have to do a biopsy? Well, the answer is probably not. We looked at a number of patients with late relapses in membranous, and if they were, all the ones that were idiopathic PLA2R positive, turned out we rebiopsied them to be PLA2R positive anyway. But clearly, she is relapsing at this point. So what do you do for a relapse at PLA2R positive? She's had a long course of TAC already, so that's not going to be the answer. Do you use cyclophosphamide? Do you use cyclophosphamide alternating with months of steroids? Do you use rituximab? Would you try avacopan? So a number of different possibilities here. Avacopan, of course, is FDA approved for ANCA-vasculitis, and we don't have a big series, any significant series of complement blockade in membranous yet, though it's being studied. But in any case, this is what KDIGO says. If they had rituximab, they relapse, try it again, especially if it's more than 6 months out. A lot of our patients with rituximab get 2 doses and 6 months later, a single dose of rituximab. Some of them get another dose 6 months after that. If they're on a calcineurin inhibitor plus minus prednisone, you can use rituximab plus minus the calcineurin inhibitor. Or you could use, if they had cyclophosphamide, you could use any one of those possibilities here. She had rituximab, so she is clearly in a group here that, or in a group that you could certainly consider cyclophosphamide here as well. So there's no doubt that rituximab has moved up in terms of therapy for membranous nephropathy. This is taken from the Mentor trial, where we looked at 130 patients randomized to cyclosporin or to rituximab, the complete or partial remission rate in this population. This was all a group of people who they were high risk, heavy proteinuria and heavy proteinuria for at least a 6-month period to get in there. And if you look here, it was 60% response rate, only 20% response rate in the cyclosporin group over time, because they all did well initially, but rituximabs were not relapsing later on. This has been confirmed by the ribociclo trial. The ribociclo trial showed the same thing, that they couldn't find any difference initially between either the remission of the proteinuria here, the preservation of GFR in terms of this. If you look, here's program, okay, and response rate, that it's the same if you use cyclophosphamide or if you use rituximab. So this is what we did. She was started on entecavir for therapy and trying to prevent hepatitis B reactivation. Now, by the way, let me say, there are 2 things you should check before you think about using rituximab: hepatitis B antigen and core antibody. Check them, and check the quantiferin gold for TB. You don't want to treat somebody with tuberculosis because you can activate that as well. And she was treated with rituximab, and she ended up having a complete remission. She had a second relapse in 2021, 2 years later. She got a single dose of rituximab and went into complete remission and remains in complete remission. She stayed long-term on her entecavir, that we could stop it at any point. She doesn't want to stop it. She's very opinionated on this. If she has late relapses, we can just redose, probably with just 1 dose, but if years out, you might want to use 1 and then another 1 2 weeks later of rituximab, but doing very well at this time. So that is case 2. Let's move ahead. Case 3 is a 22-year-old female who presents with proteinuria during pregnancy. Now, of course, that's always the biggest challenge for nephrologists, but I can tell you this is not a pregnancy case, okay? She's had 2 prior miscarriages, that her screening during her 3rd pregnancy noted proteinuria, 8.6 grams a day of proteinuria. The creatinine was normal. She had marked edema, but she delivered at 35 weeks and a healthy child. And she was delivered actually because her blood pressure was increasing at this time and the creatinine was going up. Postpartum, her creatinine peaked at 1.3 and then started to come down. She appeared well. She had some edema. Blood pressure was controlled on an ACE inhibitor. When she was worked up, and again, this is a common source of referral to glomerular centers. If you take that, anytime you put a dipstick in somebody's urine, you are like, if you find proteinuria, hematuria, that's the kind of person that gets referred. So insurance physicals, pregnancy physicals, sports physicals, army physicals, they're just constantly dipsticking the urine. I'm sure if we did it in everybody at every routine visit, we'd find many more. In any case, she had 3+ blood, 3+ protein, 5 grams of proteinuria per gram of creatinine. The albumin was low. She had dysmorphic red cells and granular casts. CBC wasn't bad. She's a little anemic. LFT's normal. Term platelet count normal. Negative ANA, ANCA, negative hepatitis B, hepatitis C, HIV. Her complement, her total hemolytic complement was very low. Her C3 was very low. Her C4 was normal. So she had an interesting complement pattern here, which was repeated. A diagnostic procedure was performed. This is like they say in the CPCs in the New England Journal. A diagnostic procedure was performed. Well, you don't have to be a rocket scientist to know that the procedure was a biopsy of the kidney. First, let me just say that you get low levels of complement in a number of diseases. And I always tell the fellows, you see low levels of complement, for the house staff, I just tell them, remember the 4 diseases that give you this. For the fellows, I say, when you see the low complement, post-infectious is usually a low C3, often a normal C4. Lupus gives you both low C3 and C4. Cryoglobulins usually give you, including hepatitis, cryoglobulin, hepatitis related, usually gives you a low C4. And idiopathic MPGN or C3 glomerulopathies give you a low C3. So knowing the pattern is pretty important. Yes, heavy chain disease, if it's an IgG1 heavy chain or an IgG3, can give you low complements, and cholesterol emboli gives you low complements sometimes. But again, these are the big 4 that we teach the house staff and the fellows. If they can remember the low C3 and post-infectious and C3 glomerulopathy, low C4 and cryos, I'm very happy. Everything else is normal. I just don't bother to remember, just remember these 4. And for a fellow, you probably have to remember those as well. Okay, so here's her biopsy. So you can see here's a glomerulus that's shrinking down with periglomerular fibrosis. Here is a very large glomerulus here that there's clearly an increase in cells here. It looks like an MPGN. If you look at other glomeruli, they have characteristic membranoproliferative features. The old name for MPGN was lobular glomerulonephritis because it often looks like the glomerulus is cut into distinct lobules here. But again, all of these are proliferative here. And if you look close, you can probably see the double contours of the glomerular basement membrane. Now, when we looked at the IF in this patient, this MPGN pattern, there was no immunoglobulin. IgG, IgA, all negative. C3, heavy deposition of C3. Kappa and lambda both negative. So again, it confirms there's no immunoglobulin. There is only C3 in there. And when we looked by electron microscopy, there were some endothelial, some epithelial scattered deposits, mesangial deposits. This is C3 glomerulopathy. So C3 glomerulopathy, which can be in 2 different forms, is due to abnormalities usually of the alternate pathway, of complement. It's not the classic pathway, and it's not the lectin pathway. That's by mannose-binding lectin from bacteria, etc. And it's the alternate pathway that's involved and overactivated. Now, I'm not going to go through the pathogenesis of this because Helmut went through this at great length and showed you a little more of the pathology and everything. So again, you can just go back to Dr. Franke's excellent pathology lecture and, which had a case of C3 glomerulonephritis. It does come in 2 patterns. Here's the glomerular by light, and again, you can see this MPGN type pattern, C3 positive, IgG, IgM, IgA, and lambda and kappa should be negative. The 2 flavors are dense deposit disease. You see the ribbon of dense positivity all along. It comes along Bowman's capsule. It comes along every glomerular capillary loop. And then the other, the C3 glomerulonephritis, which has electron-dense deposits, but there's no big grand band of density here. So how important is it if you have one or the other? Well, in our series from Columbia, which was 111 patients with this, that we had 87 with C3 glomerulonephritis and 24 with dense deposit disease. And that's what's usually seen. It's about 3 or 4 to 1. You see much more C3 glomerulonephritis. When we followed them out here for a long period of time, 69, 83 months here, the percentage remission was about the same, doubling the creatinine about the same, progression about 10% versus 0, but needing a transplant the same, and end-stage renal disease. If you add all the good and all the bad together, they came out about the same. And this looks at the time course here. You're looking at months here in adults with this. Here, the average age was 28, 40. You're looking over here, here's 50 months. That's a little over 4 years. Here's 120 months, 10 years. So it's about a 50% survival in terms of the kidney survival, both of these. So one of the striking things is that we had recently a therapy. This shows you a Spanish study where patients who got immunosuppression here for C3G, now these weren't dense deposit, they were C3 glomerulonephritis, but they did better with immunosuppression than no immunosuppression. And if they got mycophenolate as part of the immunosuppression, they did even better. In fact, everybody did well. Well, of course, there are no studies where everybody does well. I mean, you're looking at you can't get everybody, 100% of the people to do well. And so, if you follow them long, this is only a 1-year follow-up. If you follow them long enough, some of those patients aren't going to do as well. But it was interesting when we looked at the 73 patients who got immunosuppression for C3 glomerulonephritis or dense deposit disease in our hands, the group that did the best, almost 70% with mycophenolate and or steroids, either alone or with steroids, did well. If you take steroids alone, it was down to 40%. If you take a calcineurin inhibitor, it was down even lower. Rituximab's down here, cyclophosphamid's down here. Mycophenolate group did the best again when you follow them over time, and we had a longer follow-up here. So again, it suggests that mycophenolate does treat C3 glomerulonephritis and dense deposit disease. In follow-up, the Spanish Glossin group, which is their glomerulonephritis group for the country, looked at 97 patients with C3 glomerulopathy, 84 with C3 glomerulonephritis, 16 with dense deposit disease. If you look at the remission rate of the 42 who got MMF, 79% remission, complete and partial, kidney failure, only 14% over follow here. And if you look at other immunosuppression, not nearly as good, and no immunosuppression did the worst. So again, now they had some variables that they thought were related to this, but the most important thing is the mycophenolate, again, in their hands, did very well. Most of those patients obviously are C3 glomerulonephritis, not dense deposit disease, but I think, we've shown that the course is pretty much the same. If you look at other therapy, eculizumab, a blocker of C5, so here you're down in the pathway, all the way down in the complement pathway. But again, this is a disease of the alternate and complement pathway. You might think it would work well. Some people do well, some people don't. So here you're looking at complete and partial remissions. Here's complete remissions in adults. Here's partial remission in blue. Here's no remission in red. So again, not everybody is responding well to this. So what did we do? At this time, we started her on mycophenolate and steroids. We increased the mycophenolate up to a gram twice a day. The creatinine worsened for a while and then slowly improved. Okay. Later, we stopped it. We tried other therapies. We tried rituximab here that did not seem to help at all. That we tried eculizumab. It worked for a while and then didn't work as well either. And she slowly progressed over time. We have newer therapies now, which we did not have just a few years ago. The most important things are the ones that we're studying for complement blockade. Now, again, as I said, Helmut went through the pathophysiology of the possibilities here, but I will point out that 3 drugs have been looked at significantly here. One is a factor D blocker, danicopan, that did not work well enough to continue studies on it. That paper is in press already and has already been accepted by a major kidney journal. We were in that study. The 2 other studies we're in is one is a factor B blocker, iptacopan, a Novartis drug, which blocks very nicely here. This was in the New England Journal just 2 weeks ago because in paroxysmal nocturnal hemoglobinuria, it led to excellent results. That's a disease where people die from their disease and thrombosis and anemia and everything. And of course, in here, it was like 100% survival. So again, that will lead to the approval of the drug for that. Pegcetacoplan blocks C3. That's already FDA approved for paroxysmal nocturnal hemoglobinuria and for eye disease that's related to complement in the geographic atrophy, a very bad form of macular degeneration. So again, these are promising drugs that we hope you could use eculizumab, you could try avacopan, but again, right now there isn't good enough data in that, and the newer drugs here are very close to where they'll be able to present their data to the FDA. So promising for the future here, but think of C3. Helmet showed you different variants of it. It certainly is something that you're going to see in practice at some point. Okay, the last case now. The fourth case has new onset of acute kidney injury in an elderly woman, an 81-year-old female who presented with altered mental status, decreasing urine output, poor appetite. She had no fever, chills, no other symptoms. She's been on losartan and blood pressure medicine. Her BUN was 2 months ago, was 23. The creatinine was 0.88. She had a normal CBC, no protein or blood in her urine 2 months ago. She went for a routine checkup. She's actually very sharp and very reliable. She came into another hospital drowsy with a blood pressure of 147/60, heart rate in the 50s and 60s here, clear lungs, no edema. Her BUN was 87, from 23 to 87. The creatinine went from 0.8 to 10.6. Albumin was down at 1.9. She had 3+ proteinuria, 2+ blood, and RBC casts. So other things we had some normal serology here. That normal, we had a negative hepatitis B, hepatitis C, ANA, all negative. Her immunofixation was negative. Her chest X-ray or CT of the lungs was basically normal here. Her CT scan of her ultrasound of her kidney had normal-sized kidneys. She had a catheter, a tunnel dialysis catheter placed and started on 3 times a week dialysis. And she was given Solumedrol, and she was started on plasma exchange twice a week. Now, why was this done? Well, you can think of what other lab tests can you do. There are a number of lab tests that can be done here. But is this patient nephritic or nephrotic? Yeah, you want to do an ANCA here because it's acute renal failure. There's red cell casts. But she also has a very low albumin in terms of this. Most people who have RPGN don't get that low in albumin because their glomeruli are filled with proliferation. So she's nephritic, nephrotic here. But you certainly would want to get an ANCA. You'd want to get complement levels. You'd want to get anti-GBM, etc. What other therapy would be used before a biopsy? None in this case. In this case, she's on dialysis. You gave her a pulse of steroids. She's getting plasma exchange. You're treating her for anti-GBM disease. You're treating her for a very bad involvement in terms of with an ANCA vasculitis if you think the plasmapheresis exchange works. Anyway, her kidney biopsy was sent to Columbia on the 7th day. Here's what it showed. No surprise. Great big crescent. You can barely see the glomerular tuft in the middle of this big crescent and glomerulus. Here on the right-hand panel, again, big crescent, glomerular tuft is just totally compressed by this. Here's another one. So 2 of 12 glomeruli had necrosis and significant major crescents here. But the other glomeruli had something interesting. They had little outpouchings along here, along the basement membrane. And again, our pathologists, they hone in on that basement membrane, especially as soon as you tell them it's a low albumin and there's significant proteinuria. You can see them along the line here. The IF suggested 2 diseases. Anti-GBM disease, because there's linear staining all over the place. There's also, again, the outside is a little bumpy, and that's unusual for good pastures because you usually get linear. You get a smooth inside and a smooth outside to the basement membrane. So we look at the EM. We have electron-dense deposits scattered evenly all along the basement membrane here. And thickening of the basement membrane. So the diagnosis was focal necrotizing and crescentic GN with linear GBM staining compatible with anti-GBM disease. that recellular crescents 2 with fibrinoid necrosis, but membranous nephropathy, stage 2, PLA2R negative, and acute tubular injury. So what do we think of the course of this patient? What do we think is going to happen? She's 81 years old. She's on dialysis now. That she's also getting her plasmapheresis and immunosuppression, etc., prednisone. So a recent paper that really gives us a view of this. It looked at 123 cases of anti-GBM disease. About half were male, half female. That 49% had anti-GBM alone. A third of them had anti-GBM and ANCA together. And again, that's a common pattern that you see. The survival at 5 years of the kidney was only 30-something%. And only 1 of 15 patients with focal disease had ended up with end-stage renal disease, while if you had over 50% global sclerosis or patients with 100% crescents, none of them came off dialysis. One of the most impressive things was what happened over time, because this was a long time series here. So if you look at those from 2007 to 2015, that's 1986 to 2000 at the bottom. You can see it was 25% kidney survival over time. 2001 to 2006, the same. 2007 to 2015, it bumps up to 50%. I bet it's up to 60, 70% kidney survival now because we act much more quickly. Likewise, if you had focal involvement, the top panel here, you did much better than if you had a lot of crescents, solid line at the bottom, mixed patterns in the middle, or sclerosis at the bottom. So the renal outcome has clearly improved, though it's still not great. Plasma exchange, steroids, and cyclophosphamide are still the first line of therapy of anti-GBM disease. There are anecdotal cases with all kinds of therapy, azathioprine, MMF, and rituximab. And the findings on renal biopsy can predict the outcome. Again, if you have over 50% glomerular sclerosis or a large percentage of crescents, you're going to do badly. Patients who are dialysis dependent do not do well over time. So what happened to our patient? So she had a creatinine of 10, positive anti-GBM to 180, ANCA negative, okay, PLA2R negative. She's treated with dialysis, plasma exchange. She was referred about a month later. She was at a rehab center, and then she was referred to us for a second opinion. She was still on 40 milligrams of prednisone a day, making a reasonable amount of urine, though. The creatinine we found pre-dialysis was 3.6. So we tapered off the dialysis, removed the tunnel dialysis catheter, followed her for a while here at, it's a pretty short time. The creatinine came all the way down to 1.6, but the anti-GBM was still positive. And then it started to go back up again. So at this point, she's off steroids. Would you treat her more now or just sit tight? Tough decision in an 81-year-old person. I want to point out, if you think, what's the data on other things? There is data on rituximab. This is a series of 22 cases that Andy Bombeck put together in the literature after plasma exchange. Without going, this is a single case of it, but the majority of the patients did well, whether they had pulmonary hemorrhage or not. And we actually looked at our own series of patients who had had membranous plus anti-GBM. We had 12 patients at Columbia over the years that had that. And only 1 of 5 that we tested PLA2R was positive, so most of them were negative. And there's a recent series from the Mayo Clinic which shows the same thing, that they all were anti-GBM antibody positive. Most of them got plasmapheresis, most got cyclophosphamide, 2 got rituximab here. But the renal recovery was only 2 patients. 3 patients got a transplant and did okay. 2 died, but only 2 of them recovered renal function, the youngest and the oldest. And the oldest was our 81-year-old patient. She was given rituximab. Her creatinine came further down after the rituximab. Her albumin came up. Okay, so this was pretty good. She had a good low protein creatinine ratio and no anti-GBM antibodies. And since it's a one-shot disease, we expected her to do well. Except later on, she had a relapse of the membranous with nephrotic syndrome. And her albumin started going down again from 3.3 to 2.5 to 1.5, and her proteinuria was 12 to 14 grams a day. Anti-GBM negative, PLA2R negative. So we put her on TAC. We tapered down the TAC over time as we gave her 2 more doses of rituximab, complete remission off TAC, no recurrence after that time. So she's had relapse of the membranous once. Her anti-GBM is cured, presumably here. She's been followed up now for a long period of time. It's since 2018, 2019. She's 86 years. It's 5 years old now. Her creatinine is 1.35, no blood, no protein in the urine. She is active, feels great, is very active in her facilities and her home, care in terms of this, lives at home in terms of sees the great grandchildren all the time, that it's a cure. So again, what do we learn from this? Well, you can have more than one disease. That's important. Here's anti-GBM with membranous. Anti-GBM often comes with ANCA positive. You got to think about 2 diseases. Secondly, don't give up. Just because you have an 81-year-old who's on dialysis, don't give up on them, especially in the older patients in terms of this. Because again, there are other forms of therapy that you can use here rather than giving them big doses of cyclophosphamide and wiping out their bone marrow. So that there is hope in terms of this. And this is an interesting double entity that occurred in this patient. As I said, there's a recent series that I've seen an abstract form at the ASN from the Mayo showing, again, very similar, mostly RPLA2R negative, but you can get a response to therapy. So with that, I finished up the 4 cases, ran over maybe a minute or two, but I think we're ready to go ahead with the questions and answers. Now, to do this, I have to do something fancy for a minute or two. So I have to come out of this and go back on in a different way. So given that you have a stretch, you can run to the bathroom, but very quickly, or you can stand up and stretch a little bit, and we'll get to the questions and answers now. Thank you.